Hello, and welcome to the JAT chat presented by the Journal of Athletic Training, the official journal of the National Athletic Trainers Association. I'm Dr. Kara Radzak. I'm coming to you from the University of Nevada, Las Vegas, and I'll be your host for tonight's event. The purpose of tonight's event is to provide an opportunity for a forum for athletic trainers and other allied healthcare professionals to ask questions and discuss a recent commentary published in the Journal of Athletic Training. Today, we'll be discussing the commentary considerations for athletic trainers, a review of guidance on mild traumatic brain injury among children from the Centers of Disease Control and Prevention and the National Athletic Trainers Association. This is a really important commentary that we'll be discussing tonight with one of the authors, Dr. Johna Register-Mihalik. Dr. Register-Mihalik is an assistant professor in the Department of Exercise and Sports Science and a member of the Matthew Gefeller, sorry about that, sports-related traumatic brain injury research center at the University of North Carolina at Chapel Hill. In order to make tonight's event work as smoothly as possible, we ask that you submit your questions in the Facebook Live chat section or as a tweet to @JAT_NATA using the hashtag JATchat, all one word. At this point, I would like to introduce Dr. Register-Mihalik. Thank you for taking your time to speak with us today.
Thank you very much for having me. I look forward to answering questions and talking about management of concussion and mild TBI in kids.
So, can you give us a little bit of an overview of what went on to creating this commentary in JAT?
Absolutely. So the purpose of the commentary was really to provide athletic trainers an overview of how we sort of fit into mild traumatic brain injury and concussion management in the larger spectrum of medicine. There were also a combined body of 9 specialty commentaries that came out of the guidelines, one that was directed at pediatricians, one directed at emergency medicine professionals, and of course ours. So there were others that kind of pulled us all together in this space of management of mild TBI, because the guidelines are really meant to be a framework. The goal of the guidelines was really overall to improve diagnosis and management of mild TBI among kids, because prior to this document, there really had been no combined body of evidence that was specific to the pediatric population and diagnosis and management of mild TBI. So that was kind of the impetus, I think, behind the guidelines, and that pediatric MTBI work group that the CDC and a federal task force put together to publish those guidelines, as well as a corresponding systematic review. And again, the purpose of the commentary was really to sort of help translate how we as athletic trainers fit into that spectrum, and then where these guidelines fit in the context of our current position statement.
Thank you. Can you give me a little bit of information of how athletic trainers fit into the development of these guidelines? Was there anybody on the panel that was an ATC?
Absolutely. So there were 2 ATCs, I believe, on the panel that were part of the authorship team. If you go and look at the guidelines themselves, the other professions that were represented, just to give that spectrum, were of course athletic training, emergency medicine, family medicine, neurology, neuropsychology, public health, school health, nursing, pediatrics, physical therapy, and sports medicine as a whole. So it was a very sort of wide spectrum of individuals who might be involved in this management, with, of course, athletic trainers being on that authorship team and being part of the contributory group to the guidelines and also to the systematic review.
So for those of our listeners that have got an opportunity to read the guidelines, they'll see that it's a pretty brief commentary. But one of the things that's nice is the extensive tables that you guys came up with. Can you kind of talk us through how you decided to present the CDC's guidelines in relation to what's currently out there for athletic trainers?
Absolutely. I think one of the biggest challenges that we face as athletic trainers is this really sort of evolving and emerging space around MTBI and concussion. There's numerous guidelines, there's numerous consensus statements. The evidence is emerging very quickly. And so one of the things that we wanted to do was kind of try to summarize the guidelines in relationship to how that fits into our position statement. Because our position statement is very specific to our profession, and quite frankly, in some places is much more detailed than the guidelines, because the guidelines were meant to be a broad representation. But we wanted to try to bridge those together. We often get that question just sort of as we're out talking to clinicians, how does the Berlin Concussion International guidelines fit in with our position statement? How do we merge those two if there's a difference in information and those types of things? So we wanted to put together a summary that would help do that. And I think the first table, table 1, does that. So it sort of gives an overview of the guidelines and then which one of our recommendations from the 2014 position statement align with those guidelines. I don't think we as athletic trainers probably looked at the MTBI guidelines and thought that anything was earth-shattering. I think a lot of us, know how to do this well. It's something we've been on the front lines of dealing with for a long time. But I think it's a great refresher of how we all work together as part of the sports medicine team. And it may help us also communicate with other members of our sports medicine team who might not be as sort of entangled in the concussion or MTBI world, and knowing how our practices intermingle with those larger guidelines, I think is really important.
Thank you. So they came up with 6 important clinical questions that they said that guided the development. One of the things that I noticed about the guidelines that really came out to me was the emphasis on return to learn.
Yes.
Can you give us a little bit of a brief overview of what the CDC guidelines present with return to learn?
Absolutely.
And sources that they provide for us?
Yeah. So, I think that's been a big focus of not only just in athletic training. The folks at, at AT Still University have been doing an outstanding job sort of trying to understand those pieces of the return to learn process. There are states across the country that have, great models and programs that we've all been looking to. But I think it's an area that, certainly doesn't have as much direction. There's not really a standardized return to learn process. I think depending on the school system that you work in, people may have no knowledge of that even being a process that people need to go through. And so I think, when you look at the literature and the problems that have emerged for children, returning to school is one of their biggest issues, whether they be an elementary school patient or a high school student athlete. And so, that was one of the reasons that was such a huge focus here, was so that, there would be some kind of guidance for your general practitioners and clinicians to have that this is a really important component of management of traumatic brain injury, because it's really the primary thing that children do, at least for 9 months out of the year when they're on a traditional school calendar. So there are some outstanding resources that the CDC has developed. I know we're going to provide that link at the end, but even if you just Google CDC mild TBI guidelines, return to learn, it'll take you to a page where there are sort of resources for parents where they can look and see what that process might look like. And reinforcing that gradual return to learn process, where you may have to have some adjustments early on before you can return to a full school day, involving that full comprehensive team as much as possible in that process. But some really sort of resources that provide targeted guidance, but in a way that could be shared with many individuals that might be involved in their child's return to learn process, or if they need to share things with clinicians who maybe aren't as familiar, those resources are great for that as well.
And regarding return to learn, one of our questions from the viewing audience at home is, how would you recommend advocating for return to learn in the school environment? And who are the most important stakeholders to engage?
That's an outstanding question. One of the things that I know that we've done in North Carolina is, there's a big component of healthy students in a lot of state boards of education, or, here in North Carolina, we have the Department of Public Instruction, and one of their big goals is having healthy students. And that has helped a lot in terms of forming traumatic brain injury teams or individuals who may be knowledgeable about this within sort of the higher level of education, but also kind of pushing things down to the school level. So I think one of the ways to advocate is thinking about a healthy student. And I think most schools think about that in a different way. They often don't think about sports and return to learn, but it's a way to bring back what we do into the bigger picture in the school system. So that's one of the ways. Another person, some people to think about in the context of that are, depending on what individuals have available, which I know is very varied in their school setting, school counselors can be really helpful in that process and an advocate. If you have school psychologists, they also can be a huge component, or if you have both of those, certainly pull them in. Ourselves as athletic trainers may need to be the center of that team until everyone gets on the same page. And then educating teachers, we found that to be really helpful because we've even found, and we get this question a lot, where maybe there's even a policy within the school, but the teachers aren't aware of that. And so there's a lot of pushback for the kids when they return and have these adjustments that need to be made because the teachers aren't aware of that context. Another person that our individual that sometimes I'm not sure we always think about, but they have a great skill set, are speech and language pathologists. They do quite a bit of work with information processing and cognitive integration back into normal activities. And so that may be another person that could be part of that team. In addition to obviously the family being involved in that process and the administration, to the point that you may need that help to form that team.
Thank you. I never thought to include a speech pathologist on the team, but particularly if you're working with anybody who's in the lower grade levels, they probably have one on staff.
Right. Or there may be one every 3 or 4 schools. That's another model. So they might not be at one school, but there may be one in a county or one in a school district.
Great. Kind of along the same thread, another question came in of, how can I discuss the mild and the long-term consequences of concussion with a patient or even a patient's parent in an evidence-based way?
So is the question about long-term consequences? So how do you bring up that discussion, or if a parent, okay.
The midterm and the long-term consequences. And they say, particularly given the current and potentially overblown focus on conditions like CTE.
Right. I think that's something we're all dealing with, whether we're primary clinicians or our primary researchers. In a lot of ways, the messaging in the media has often outpaced the science, or the way that things are phrased in the media. We know scientifically what that means, but potentially, a person who might not be as familiar with our field may not know exactly what that means. And so that's a huge challenge. So I really appreciate that question. I think one of the things that we can do is talk about some of the evidence that shows that concussion is being managed better now than it ever has before. That people are not returning to play on the same day. If you look at studies that have been published in the past 4 or 5 years, there's a much greater separation between an injury occurring and when someone is returning to participation. We don't see near as many recurrent concussions, so injuries occurring within the same short period of time or within the same season. So I think there's a lot of things that are moving in the right direction. So that's data that we can share with people in terms of those midterm consequences. I think other pieces of information to share are that some of the things we just don't know, right? And so we do our best to protect our student athletes by limiting contacts to the head, by making sure that we're managing concussions with the best evidence that we have possible. But that in a lot of ways, in the big picture, some things are safer now than they've ever been because we have knowledge, we have practices that have never been in place before until now. I think the other thing that we always tell people is, we have to assess what the risk and benefits are. And we have to balance that out. And for some families, that risk is too great, and that's understandable, right? But we have to help them understand that risk in the context of where their child is, what sport their child plays, and what the long-term goals or long-term outcomes might be for that individual. So there's not a great answer other than trying to frame it in the context of the evidence that we have about concussions, and about the decrease in repeat concussions, that, we're starting to see that when concussions are managed properly, you're much less likely to get another one, that we're working in all the ways that we can to decrease impacts to the head, right? Through decreasing contact practices, changing the way that individuals behave while they play, playing by the rules. But, if an individual has too many concussions, if those injuries are closer in proximity to each other, if there is, less force causing subsequent injuries, those are kind of red flags that maybe we need to pull back, and think about a different decision for that season, or maybe for that sport, or a lifetime.
So in addition, along the line of talking to parents about the disconnect sometimes between what they see in the media and what they might desire versus the science, one of the CDC recommendations revolved around imaging.
Yes.
And can you touch a little bit about what their recommendation was on imaging? And then in addition, what kind of advancements have occurred with diagnosis and acute management within the last year or two?
Yeah. So I think, the most important recommendation, when you look at all, I think the first four recommendations are all around some kind of imaging, whether that be CT, X-ray, MRI, or PET scans, is that, you should not, or do not routinely image patients that are suspected of only having MTBI. Now, there's PCARN rules and other decision rules that are out there that help determine in a setting the risk of intracranial hemorrhage and should an image be conducted. But as you, mentioned, there's a lot of parental insistence that happens in this heightened climate. And so, but again, this review of literature, this body of experts, and I think those of us who are in the field recognize that, that's not a useful tool in terms of mild TBI and concussion, because we know that it doesn't pick up on that injury. And in a lot of ways, it gives people a false sense of security. I mean, I think we've all dealt with the patient that said, well, the image was clear, so they're fine, right? They don't have a concussion, it's okay. And that's not the case. And so I think that's a really important recommendation, because now we have a document that we can share with our ED partners, with our community physician partners, to really start spreading that messaging. And I think when sort of the sports concussion sort of incidence rose, when the state laws were passed, there was a correlation with sort of an increase in imaging in the EDs of sport-related injuries along that time frame as well, for those reasons that you just mentioned, sort of this heightened awareness and this fear. So I think using this document to help support the idea that there's no reason to routinely image individuals who don't have a risk of intracranial hemorrhage is one way that this document could be used in a really positive way. I think the other thing is really using that idea as an educational point. We do a lot of work out in our middle schools and in our youth sports in the community. And this is one of the most common misconceptions still today, is that, we can image someone and know if they have a concussion or not. And that even though those images are clear, that you can still have a concussion. I see a lot of parents in these meetings and educational sessions that, are like, wow, I didn't realize that, right? So I think that's a really key education point, and these guidelines can help us maybe support helping to push more for the different types of measurement and tools that need to be used with concussion and MTBI.
So on that same point, we have another question saying, how would you recommend ATs start dispelling myths about biomarkers and
Goodness.
their ability to diagnose concussions and concussion recovery?
Yes. I think one of the best examples in the past couple of years of the media headlines being very different than what the actual study found. There was the study that looked at the biomarker indicated moderate to severe TBI, but the headline said that it was diagnosing concussion, right? And so, we had parents asking us these same questions, and there's a lot of parental insistence in that space. And the guidelines certainly go in and say biomarkers are research only now, right? We do not have a biomarker that in and of itself at this point in time can tell us if a person has a concussion, and really clinically if they're recovering. Are there some things on the horizon, I think, that used in the context of the addition of a symptom checklist and the context of our clinical evaluation that might be useful in the future, absolutely. But I think we're a long way away from having something, swabbing someone's cheek on the sideline and being able to say yes or no, thumbs up right there. And so I think helping to use evidence that exists that shows right now we don't know that. We don't have that answer, and that, we need to do these full clinical evaluations to make sure that we're making the best decisions. But that's a great point, especially with the media really wanting to find that answer quickly and even kind of tweaking headlines to make it sound like we potentially do.
So again, it's nice to have a document from the CDC saying biomarkers cannot be used.
Yes. Right. And even sharing that, I mean, I think we have fellow, practitioners and clinicians who, again, may not deal with concussions at the same rate that we do. And perhaps they may be trying to find information and not looking in the right place. And so this document is a great place to start with a sports medicine team or people in the community to kind of help bring those more in alignment with what the evidence actually shows for us.
So let's continue talking about diagnosis. One of our questions from the viewers is, what areas in diagnosis have changed the most in the last year or two? And I would add to that, what does the CDC guidelines add?
Yeah. So I don't know that the CDC guidelines add anything to what I think we probably knew about diagnostic tools. I think the biggest push in the CDC is using valid and reliable tools. And as a clinician, knowing the tools that you're using. I think we've all heard the saying that a fool with a tool is still a fool, right? You can have the best tool in the world, but if you don't know how to use it and interpret it, it's not providing us with much information. And if the tool in and of itself is bad, right, it's not giving us what we need it to give us. And so I think, the CDC's recommendation of using valid and reliable tools is right in line with our position statement, which clearly states those things. So I don't know that it adds a lot other to reinforce the importance of using valid and reliable tools, and specific to the symptom checklist, age appropriate tools, right? Because, when we use the regular 22 item checklist within a 7-year-old, they don't understand those words. They don't understand the ratings, right? And so the child scat actually has a different set of symptoms. But to be fair, that symptom, that sort of child list hasn't been as well validated as the 22 item list has either. But it's more kid friendly, right? So I think that's maybe what it adds, is really reinforcing the age appropriateness and validity. In terms of new developments, the way that we evaluate a concussion, that multimodal approach, I don't think has changed that much. But I think the addition or the inclusion of potential visual vestibular screening measures is probably the newest addition to that gives us another tool in our toolbox. But as we've always said, none of those supersede another. Just because you have a clear visual vestibular exam, if you still have neurocognitive deficits or still have symptoms, that's still an indicator that something in that puzzle is not quite right. So I would say that that's probably the biggest addition. I think it gives us another opportunity and another tool to be clinicians. I know the VOMs, for instance, you ask them to rate symptoms, and that's actually how, they've done a lot of the scoring with it. But I find the most valuable part of any of the visual vestibular measures is actually watching the patient. You can't fake that you're getting dizzy and can't be stable after you do a visual motor sensitivity test from the VOMs, right? So I think it just adds another tool and maybe a more objective way in that process to think about our multimodal assessment. But I'd say that's probably the biggest addition, that may be the most common over the past 5 years.
Going back to the graded symptom checklist and symptom reporting, we've got a question of, what suggestions do you have for improving the accuracy of symptom reporting among young children?
Oh goodness, yes, for sure. That is a hard question. I have a 7-year-old, so I identify with that personally and professionally. I think one of the things that's challenging are vocabulary, right, and them understanding what we're asking. So that's one issue. So making sure that the vocabulary that we're using or the terms that we're using are something that they are able to identify with and that are age appropriate. I think the other hard part, and this is not really answering that question, but I think is along that same vein, is, kids commonly complain of some of these symptoms, a headache, a stomach ache, I'm tired, those kinds of things over the course of a school week. So teasing that out from, either them trying to get out of going to school or either some other things that may be contributing to that, perhaps at the end of a school day, I think is also a challenge. So not just the accuracy, but teasing out where the source of those symptoms may be, I think can also be a challenge. But I think one of the key things is trying to find terms of vocabulary that they can most identify with, so that they are able to explain the way that they feel.
So again, in this early childhood population, should we be using symptoms as the primary indicator of recovery?
Right. And I think that's a challenge for any age group because again, we need it because it's a patient reported outcome, right? They're telling us how they feel. And we certainly need those measures because that's a measure of their perceived function and how they feel. But again, it's also subjective in a lot of ways. And when you get in older individuals, they're often not telling the truth potentially because they want to return to play or they want to return to school. And so I think, trying to find objective measures is on all of our agenda, I think, as clinicians and as researchers. I think that's where some of these visual vestibular measures may be helpful. Other more objective balance measures may be helpful. I don't think we're there yet, right? From trying to find the most objective way, but any way that we can include something that is more objective in that process to give us another piece of that puzzle, I think is really important, especially when our clinical gut is telling us something's not right about a symptom report or the way they're talking about things. Making sure that we have those other tools in our toolbox are really important. And it's really difficult to rely only on symptoms. But I know in some clinical settings, that may be the only tool that, people have available. So again, making sure that we're using the right terms and that we're actually conducting a clinical interview more than just saying, check these boxes, right? That detailed clinical interview is really important overall, but certainly when we don't have any other tools to help us make a decision.
So another question regarding recovery is, what's the typical timeline for recovery, and does it vary significantly between children and adults?
So that's a great question. So adolescents typically take longer to recover than younger individuals and individuals who are older than them. So the statement that everyone who's younger takes longer to recover than everyone who's older is not necessarily true. A large network in Canada conducted a really big study and looked at younger kids and adolescents, and actually found that those adolescents were the age group that had that slowed recovery. So certainly when you look at high school compared to college, you see a slowed recovery time frame. On average, most people don't have symptoms at 10 to 14 days, but that doesn't mean they're fully recovered, right? There's a lot of other things that could be in that process. So yes, there is a varied time frame, with adolescents often taking a longer time to recover. I don't think there's a good answer for why. A lot of development is happening at that age. There's a lot of other psychosocial considerations. There's a lot of brain, maturation that's occurring during that time frame. So there's probably physiological as well as psychosocial pieces of that puzzle. But yes, there are some differences. We typically see college athletes recover within 7 to 10 days still. You see that in the adult population. But again, 20% of people don't recover in a typical time frame, right? And that's still a lot of people. So we want to make sure that we're thinking about both sides of that coin.
And again, with comparing adults to children, differences in acute management.
Right. I think, the data would suggest that would be more conservative, right? Because we know that as a whole, adolescents are going to take longer to recover. Also, they may not be able to advocate for themselves in the same way, right? They're considered a vulnerable population because they're not adults. They can't make decisions for themselves. And so, there's typically a more conservative framework around that. You even see that in legislation, right? Because most of our state laws say if you're suspected of having a concussion in high school or middle school, you're not allowed to return the same day. Or in North Carolina, our law reads, I think, if you exhibit signs and symptoms consistent with that of concussion, you don't return the same day. Whereas at the college and professional level, that language says if you are diagnosed with a concussion, you do not return to play the same day, which is two very different things. And so I think, even that framework is set up to be more conservative initially until we sort of figure out what's going on with those individuals.
Let's talk a little bit about culture right now.
Oh, sure.
And what are there any coaches, practices, or educational resources that could be helpful in creating a better reporting culture and reducing the risk of concussions?
Absolutely. So I think there's a couple of good resources out there. It's a matter of people using those resources and how do we have coaches be engaged to want to be part of that process.
Mhm.
Some of that is policy, right? A school system or a high school athletic association requiring that coaches participate in that education. So the National Federation of State High School Associations has a course that is also in line with the CDC's coaches training. That's a great resource. The CDC also has resources for coaches, and some of those resources can even be sort of watermarked with your school or your clinic or your organization, so that you could brand and sort of be able to integrate that into what you're doing, which might make it more appealing that it's part of that culture and part of those things. So there are some great online resources that folks can be directed to, as I just mentioned. Part of it can also, be at the beginning of the year when people are meeting, can you integrate it into something that they already are doing? We found that to be helpful. Anytime you have to ask somebody to come back and do something extra, they don't like you very much, right? So if there's a way for us to find ways to integrate that into things that they're already doing in an interesting way, we found that to be helpful. But I'm happy to share resources, or where those resources are from the CDC and some of the resources that we've used, if we continue the conversation offline. But I think you raise a great point of, how do we change, how do we go about continuing to change that culture at that coach and sort of organizational level?
And another question came in if there's any evidence to support preseason parent education as being able to increase reporting and change the culture. Do you know of anything?
So I think there's a growing body of evidence to show that parents are really important in that process. So we just had a study actually published in the Journal of Athletic Training last year that found that, as parents' knowledge and attitudes about concussion increased or were more positive, their kids also were, right? So parents who had worse attitudes, their kids' knowledge and attitudes were worse, right? So I think that's, there's evidence of that space. Emily Crosis and her colleagues at the University of Washington have also done a lot of work in that space, really connecting this parent-child dyad relationship. And I think there is a growing body of evidence showing that that is certainly a way that we can help the overall concussion culture, is really getting parents engaged and helping them make the right decisions. Now, are there still parents that are very challenging to work with even in that process? Or do I go to parent meetings, even in the presence of this data that shows that, how much parents matter, where they're tired of hearing this, or they don't need to worry about this because their kid plays a certain sport? Certainly those things still exist. But I think there is continuing to be a growing body of evidence that reaching the parents does make a difference in what happens to the kids.
And just a few more questions for you. Is baseline testing still recommended for children in
That's a
contact sports?
That's a great question. So it depends on the age, right? Because a lot of the tests aren't valid down past certain ages, right? And I know at one point there were some pediatric tests that were being pushed out, but they're not widespread. And so I think that's where the challenge is that some kids are too young to really have a valid baseline on many of these tests. Now, certainly the SCAT5 has a child version that we could, use as a baseline. And if people have the means and capability, and that's sort of what our position statement says, you should do that. But if you don't, more resources probably better placed in putting in a really good post-injury protocol and making sure that the right parameters are being followed post-injury, and using that preseason time as an education time and setting families and parents up with, what do you do if your child has a concussion? Where do you go? What are the steps that you take? Because those are the questions down at the youth level that we get all the time. I didn't know what to do. I don't know who to go to. I didn't know the steps that I should take. And so that's a really important component of that preseason baseline period, is establishing that protocol and then making sure that there's a good post-injury plan in place.
Thank you. So what's your take-home message from the CDC commentary?
I think there's kind of sort of 5 points, and you'll see this on the CDC's website. But I think this really does sort of summarize the commentary and the guidelines overall. Is, do not routinely recommend imaging for people with MTBI. Use validated and age appropriate symptom scales, and I would add to that any tool that you're using to diagnose and assess concussion and MTBI. Make sure that you're thinking about risk factors for a prolonged recovery. So individuals with a high increased symptom burden are individuals that you want to keep an eye out. That's a growing body of evidence shows that to be the most common factor in who's going to take a long time to recover. But you want to make sure you're thinking about medical history and presentation, and kind of be able to educate the patient and their family, but also keep in the back of your mind as a clinician who might have a prolonged recovery. Provide our patients with instructions on return to activity that's customized to their symptoms. So this idea of saying do nothing for 5 days, don't get on your phone, don't look at the TV, don't go to school, evidence shows that's not what we should do, that we should have that initial couple of days, 24 to 48 hours of some period of rest. But after that, if things aren't bothering them, it's okay for them to engage in those activities. So making sure that we're customizing our plan based on what they're reporting and can do, not just on this idea that you just do nothing until your symptoms resolve. And then lastly, counseling our patients to return to activities of daily living after that couple of days of rest, because evidence is really showing that strict rest, especially over a window past that 2 or 3 days, is really not beneficial and in fact can be detrimental. So helping them get back to normal activities of daily living and integrating back into life can really improve their overall well-being. So I think those 5 points, really summarize the guidelines. I think the key take home is that, a lot of this really integrates perfectly with our position statement. So make sure we know what that says and how to integrate that. And then we can use this, again, as we've talked about many times this evening, to educate our partners and practitioners and say, hey, here's a statement that kind of helps support some of the things that we're trying to do.
Mm-hmm. And one last question for you. What research avenues are you most excited about seeing coming out in the near future to influence clinical practice regarding sports-related concussions?
Absolutely, no doubt, treatment and rehabilitation of concussion. This past month, Dr. Letty and his group published one of the first studies of acute exertion after an injury. On average, 4 days, those patients were getting subsymptom threshold aerobic exercise, and that group improved significantly over the group who weren't exercising in that acute phase under that protocol. And there's numerous studies. We have a large multi-site trial that we're conducting over 3 countries looking at early activity. And I think it's just really exciting because as athletic trainers, we do not like to sit on our hands. We want to know what to do from the time someone's injured all the way through that process. And I think we are getting there. And so I could talk all day about that, but absolutely no doubt that is the thing I'm most excited about, because it is going to, I think, drastically improve our patients' outcomes and really drastically improve and change the way that we currently practice, especially within that first week after someone has a concussion.
Great. So not biomarkers, huh?
Not biomarkers, but that might be for some people. I mean, if we had a gold standard of diagnosis, that would make us all happy also. But I'm very excited about the treatment and rehabilitation avenues that I think have a growing body of evidence that will change our clinical practice for sure.
That's the wonderful thing about research. All avenues are open.
That's right.
Yeah. So thank you so much, Johna. I really appreciate you taking your time to talk with us today and helping us translate the research coming out of the JAT pages into people's clinical practice. Thank you so much.
For the opportunity. And I'm happy to answer questions, or feel free to email me or reach out to me on Twitter or Facebook if you have any questions or want to chat more.
And anybody who's listening and watching, if y'all want to continue the conversation, please do so both on Twitter and on Facebook. Thank y'all so much. Have a good evening.
Thank you.